You're 22 when the emergency broadcasts stop making sense. The hospital where you work as a medical intern is already chaos when you arrive for your shift. The emergency room is overflowing. People with bite marks. People with fever and delirium. People who don't know they're dying yet. Dr. Morrison tells you to assist with triage. You've learned the procedures in medical school. You have the textbook knowledge. What you don't have is the ability to process what's happening in real time. A woman comes in with her arm hanging at an angle that arms shouldn't hang. Behind her is her daughter, also bitten. You're assigning them to different wards because protocol says you must. Protocol is all you have when your mind stops working. The hospital locks its doors at midnight. Not to keep people in. To keep things out. You hear them hammering on the entrance. Screaming. Then silence. The silence is somehow worse than the screaming ever was. You wonder if you'll hear that silence in your dreams. You already know you will. You spend your first night checking vitals on patients who are transforming in real time. Dr. Patel shows you how to recognize the stages. The fever spike. The pupil dilation. The moment when consciousness leaves but the body remains animated. She's clinical about it. You realize she's terrified underneath the clinical tone, using professionalism as a shield. That terrifies you more than the infected ever could. By morning, 17 patients have turned. The hospital protocol is clear but nobody wants to execute it. You're a medical intern. You haven't killed anything before. Your hands shake when they ask for volunteers. You volunteer anyway because staying silent feels like complicity. What choice do you have? 3 months later, you're a junior resident. The promotion is automatic. Most of the interns are dead or gone. The ones who survived understand things they weren't supposed to learn before finishing their training. Your responsibility has expanded beyond recognition. You're now making decisions about patient allocation. Who gets the limited antibiotics? Who gets palliative care instead? Who deserves a chance? Dr. Morrison is gone. Infected during a supply run to the basement. Dr. Patel is now the de facto head of emergency medicine, and she relies on you more than she should. You brief her on incoming patients. She trusts your assessments in ways that feel dangerous. That responsibility sits on your chest like a weight that gets heavier each shift, each decision, each patient you can't save. You lose your first patient under your direct care. Not to infection. To a mistake. You miscalculated medication dosage by a decimal point. The error was caught but not in time. A woman who came in with a treatable wound dies because of mathematics you got wrong. Dr. Patel doesn't blame you. That's somehow worse. She just nods and moves to the next patient. Everyone's doing their best with incomplete information and insufficient training. The hospital has become a fortress. Security has locked down all but 3 entrances. The basement is sealed with metal plating and warning signs. Nobody talks about what happened down there before they sealed it. A rumor suggests infected got into the blood bank. Another suggests something far worse. You don't investigate. Information is dangerous when you're trying to function. You're promoted to senior resident at 24. The title means you're responsible for training the new residents. There are 3 of them, and they're all terrified in ways you recognize from your own early days. You remember being them. You want to tell them it gets easier. It doesn't. You want to tell them they'll adjust to the horror. Maybe they will. You haven't, not really. You've just learned to compartmentalize. One of the new residents, Dr. Chun, questions your decision to stop aggressive treatment on a patient showing early infection markers. You explain the protocol carefully. The patient will turn regardless of intervention. Keeping them sedated and comfortable is mercy. Chun argues that we should keep trying, that someone somewhere survived this before. You see yourself in that argument. You crush it gently but completely because sentiment will kill everyone. By tomorrow, Chun will understand. By next week, Chun won't argue anymore. The hospital director calls an emergency meeting. The infection rate among staff is climbing above acceptable thresholds. They need to implement mandatory testing every 8 hours. They need isolation protocols for anyone showing symptoms. They need containment above all else. The director's hands shake when she presents this. She's the director of the hospital. She doesn't have answers anymore. Nobody does. She's just trying to manage collapse. A young nurse named Sarah comes to you after a shift. She's been bitten. She knows protocol. She wants you to know before she has to tell administration, wants you to have warning. You sit with her for 20 minutes in the break room. You don't call it in immediately. After her shift ends, you do. By morning, She's been transferred to the isolation wing. You hear she turned by evening. You try not to think about her name, her face, the way she asked you to sit with her. At 26, you become chief resident. It's a promotion nobody wants. The previous chief resident shot themselves in the staff locker room 3 weeks ago. Administration called it a suicide. You called it mercy. You take the position because someone has to, because refusing doesn't make the position disappear. The chief resident manages protocol. The chief resident coordinates between departments. The chief resident decides which recommendations go to administration. The chief resident becomes the point where compassion goes to die. You implement new protocols. Infected staff must be restrained within 12 hours of diagnosis. Patients showing infection markers are moved to the terminal ward. The hospital can't afford sentiment anymore. It can't afford hope. You become the person who enforces this policy without exception. Doctors who argue are reassigned to lower priority wards. Nurses who hesitate are replaced. You're not a doctor anymore. You're administration's enforcer. Dr. Patel pulls you aside one evening. She tells you that you're doing what needs to be done, but that you're losing something in the process. She's not judging. She's observing. She's worried about what you're becoming. You thank her and continue your rounds. What else can you do? The supply situation becomes critical. The basement is completely sealed now. Upper administration confirms what the rumor suggested. Infected breached the main storage area. Medical supplies are rationed to critical levels. Surgical procedures are limited to life or death situations. You're managing scarcity in a place designed for abundance. You're making choices about who gets access to what might save them. When you become attending physician at 27, the hospital has transformed into something between a prison and a mausoleum. You're leading a medical team that's technically trained for a world that doesn't exist anymore. Patients arrive. Some can be saved. Most can't. You're an attending in a system focused on triage rather than recovery, on managing death rather than preventing it. Your first major decision as attending is whether to allow an experimental treatment protocol. A researcher claims they've isolated something from recovered patients' immune systems. It might work. It might accelerate infection. The ethics board is defunct. Nobody's enforcing ethics anymore. The world isn't big enough for ethics. You approve it. 3 patients volunteer. 2 show improvement markers. 1 accelerates and dies within hours, screaming. You file the report and recommend continuation of the protocol. Your team respects you because you're decisive. They don't know that decisiveness is just comfort with uncertainty. You've learned to make choices without knowing outcomes. It's a skill you wish you'd never needed to develop. The hospital's power situation becomes unstable. The generators are working, but fuel is limited. You meet with the director and other department heads. If power fails, the isolation wards fail. The infected could reach the main hospital. Someone needs to go to the supply depot to secure fuel. It's dangerous. Multiple people will likely die. You volunteer 2 of your junior residents who are showing fatigue. They don't come back. You file the incident report while their absence is still fresh. You recommend the supply run be attempted again next week with different personnel. Administration approves. By 28, you're the de facto medical director. The previous director transferred to the administrative safe zone in the upper tower. You've never seen it. You hear it's still functional. Still organized. Still human. You run the actual hospital below, the broken part, the part that keeps the survivors alive. Your decisions now affect 300 people. Staff and patients combined. Resources allocation. Treatment priorities. Who lives and who dies because of mathematics. You review surgical outcome statistics that would have horrified you years ago. 50% success rate is now considered excellent. 30% survival among infection cases shows hope. One night, you stand in the observation room above the emergency room. The chaos below hasn't changed in years, but it feels different now. You've stopped seeing it as a failure of the system. This is the system. This is what survival looks like when everything else collapses. Dr. Patel joins you. She's retired from active medicine. She helps with research now, studying what makes some people immune. She asks if you ever think about how this started. You tell her no. She nods. She doesn't believe you, but she respects that you're lying. You're 28 and you're running a hospital that's become an engine of calculated mercy. The boy who was an intern checking vitals on dying patients is gone. What remains is competent. Necessary. Capable of deciding who deserves a chance at tomorrow. Tomorrow there will be more patients, more decisions, more calculations. You'll make them the same way you've made all the others, with full knowledge of cost and no alternative but to continue. The hospital runs on choices like yours. It runs on your willingness to become what's required. The survivors, when they come, won't thank you for your efficiency. They'll thank you for the fact that some of them survived it all. That will have to be enough.